Well, hi, everybody. Welcome to GW Center for Integrative Medicine. I'm Dr. Kogan, your co-host of this Zoomcast. And today we have Alex Sverlov. He's a wonderful guy. I met him quite a long time, and he's in Boston. And during the pandemic, he created this wonderful channel. Check it out. I'll make sure I'll put that in the link. How to optimize your longevity, life, and make it to 150. Today, we're going to talk about something different. He thought that it's important to talk about how to find the best doctor for yourself, create your medical team. So that's the topic. And Alex, I'll just go right to you.
At some point, I asked myself, what do we need to do to live to 150? And if you have applied Master of Orion or any of those games, there's like technological tree. And one of them is obviously you need support aging biology. But another, you actually have to live long enough to see the results. And then I said, okay, what do you need to live long enough?
Mm-hmm.
And I created also a list, like this 11 pieces. And one of the pieces is to have a good doctor with preventive mindset. So I think it's sort of essential because you might be exercising all the way you want, but you miss one critical blood test and
that's it.
Or forget to screen for cancer or something else. And it's good to be educated, but you still need the professional help from somebody like you.
Well, and you sent me an email, very interesting. Like I forgot how we started talking about this, but you were like, "Oh, I just lost my good doctor," and like, how do I find another one? Yeah,
I like to approach everything from put like a personal angle on everything. I have a problem, and my guess is a lot of people around me have the same problems. They just picked up a random doctor who was assigned to them at some point in their life, and they just roll with the flow, and nobody thinking, like, I don't know, if you're building a house, that's usually what I say, right? And you want contemporary, but your builder is only doing colonials, you should probably find another builder. Right.
You know, I give a different example that's much closer to the topic. I say, when you're going to a butcher, you're not going to buy a salad. And that's actually a critical aspect, because most of the medicine, the way it's practiced in the United States, have nothing to do with prevention. In fact, when the medicine use word prevention, it has nothing to do with what actually prevention is. It's a screening for diseases. It is not an actual prevention. Screening for diseases, which is what people don't understand. Screening for illness is not a prevention. Screening for illness is an early diagnosis that will allow you to use more benign treatment tools. Exactly. But it doesn't prevent anything. And
quite often it's already too late.
It's already too late. So a lot of our screening tools, like ovarian cancer, is really interesting. Like, there's no screening for it. If you diagnose ovarian cancer pretty much in any state, it's probably game over, because by that point, most likely tumor is more advanced than you want it to be. Mm-hmm. But prevention in current medical system in the United States doesn't exist. I mean, the diet, the lifestyle is all lip service. There is what's called a Institute for Lifestyle Medicine. Of course, there's also integrative medicine, multiple different training programs. So there's a movement, but it's unfortunately dwarfed by the overall medical industrial complex that basically, when they use the word prevention, they just mean screening, for which of course they make money. So it's all, unfortunately, comes back down to this one simple reality: the medicine is a business in this country.
But in a way, I'm not trying to fight the business as a whole machine, but I think that if enough people are educated and can approach finding a doctor like finding a professional, and just not rolling with the flow, but doing something ahead of time, then we can, as users, we can create enough demand to shift choices. Because as in any profession, like, there are good programmers, there are bad programmers.
Yep.
And my guess
totally.
is that there are different doctors with different approaches, with different education. So as I like to make those lists, create a list of patients. So and I'm looking for a new doctor, and actually have a couple scheduled, but before going there, I decided to sort of do it.
Talk to me.
Yeah, to do it test run on you.
Perfect.
I'm not going to tell you what the questions are yet. I'm just going to give them to you as we go. So playing a game, I'm having a consultation or a discovery visit. Like I have one scheduled discovery visit with, I think you had an interview with them. Anyway, so discovery visit.
Before you go there,
Mhm.
you just said something critical. When people go and buy a car, they're gonna test drive like, I don't know what, right? When you're getting a new doctor, you're getting a new doctor. Most people will just simply, whoever you gave me, like, come on. I mean, this is, your health is more important than the car you drive. And so it's exactly, you know, whatever you want to call this. I like you call it, what did you just call? You call it an interview?
Discovery call.
Discovery call. So perfect. I mean, I honestly think that when your doctor retires, right, and you want to find someone, you probably should have like a half a dozen of discovery calls before you decide to settle on someone.
Yeah, the same. Like if you do, again, I was talking about house, you renovate the bathroom, you don't go with the first plumber. You usually take a few quotes and get some look through reviews. You do your due diligence. But for some reason, when you're looking for a new doctor, nobody does. At least people I usually talk with, they're like, we got assigned somebody from the clinic, and that's what we do.
Because that's a status quo. And so, and I love you trying to break that. You're trying to tell to your listeners, hey, wait a second, this is critical aspect of everything. Find someone good.
And you would like to think that your health and well-being is more valuable than a car you drive or house you
than
live.
Anything else, probably.
Than anything else, yeah, obviously.
Pretty much, yeah.
And so we start our discovery call. And can you introduce yourself? Because I know, like, if you're going to be my doctor, it will be mostly me talking, right? So I want to level the field a little bit.
Right. So
your history, how
the regular doctor would say something like this. I'm Dr. Kogan. That's me. Nice to meet you, Alex. So I'm an internist, but I'm also certified in palliative care and geriatrics. And I've also done significant training in integrative medicine. I even served on the board, on the first board of American Board of Integrative Medicine. And so I've been in practice for over 20 years. Usually that's about where people will stop. Now, what I do in my practice, though, is dramatically different from sort of the regular care, because somewhere earlier in my medical school, I start realizing that I don't want to practice standard of care. I don't like the way the medicine is basically dramatically geared toward pharmaceutical and procedures, that the prevention, lifestyle, natural medicines are afterthought and not the first thought. And I said to myself, I don't want to do that. I want that to be the first line of treatment. So but I also always been an academically inclined. I like research, I like teaching, although most of what I do, 80% of what I do is clinical and administrative, as I kind of operate my own clinic. But but I like that academic aspect. And so I'm in DC. We have a large integrative medicine center where we mostly treat either difficult problems that are not solved by standard medicine, or we have a large prevention program. We have a cognitive prevention program. We have kind of a healthy aging program. We have
we'll get to that.
Women. We'll get to
in a couple of questions.
Right. But so, that's my first interest. And then I'm also,
you started in geriatrics.
Well, I started in internal medicine. So like so the way this works is that I first did a training in internal medicine before I then took a specialty fellowship in geriatrics, right? And then a little bit later, I also got certified in palliative. Interestingly, I never did a formal training in integrative medicine. As of about 15 years now, the integrative medicine is now its own standard pathway. So it's not like, it's just like you would have to take a fellowship training after your residency to go and become an integrative medicine certified physician. So that's one way you can think about finding a doctor. You can find a doctor who's certified in integrative medicine. I didn't do a formal training because when I was in training, there was no formal training. So I ended up kind of just learning it all on my own.
But you keep what's your main interest today? Let's put this.
Well, so my main interest today is to take a person who's in their 40s, 50s, and 60s, and who is saying to me, look, I would like to make it to 100 or plus, 100 plus, help me. Like, that's my main interest.
Mhm.
I also have a very specific interest in cognitive health. And so we have a program called Recode. It's a Dale Bredesen program where we have about 80% success of reversing cognitive decline. And we can talk about that if we have time. You know, so
And,
that's my
okay,
second
okay,
kind of big
okay.
interest.
And what do you do to stay current with all the research?
That's great. Great question. So first of all, we have a big team of 20 people. So we weekly meet and we bring up, like today, we're going to talk about this brand new article that just came out a couple of days ago in New England in British Medical Journal saying that 750,000 Americans die every year from incorrect care. That basically wrong diagnosis, not enough time to establish diagnosis, not having enough skills to assess properly, and that kills a lot of people. So we do journal clubs every month, roughly. So we learn the most important critical. And then I'm also an associate professor of medicine full-time at university, where I have to take a lot of CME credits every week. We have to do grand rounds. I teach. So I actually find myself the best way I learn is when I need to prepare a talk. So because you have quality of what you're presenting needs to be higher than what you need to learn yourself. That's been my motto in academia. So I probably give lecture on average two or three times a month.
So yeah, it looks like you're busy. So
I'm busy. I like it though.
All right. Yeah, I also like to be busy, but then when it comes to patients, how much time then do you spend with the patient when you have such a busy schedule?
Well, so actually, I see patients clinically roughly 2.5 days a week. So I actually have a lot of protected time because there's a lot to learn. There's a lot to learn. And my visits, if I have an insurance-based practice at university 1 day a week where my visits are usually an hour for initial and 30 minutes for follow-up. But in my own practice, usually initial is 90 minutes and then the follow-up somewhere between 30 to 60 minutes, depending on the type of a problem. And and about 50% of everything I do is telemedicine and 50% is in person.
So if I come to your, let's say that insurance-based practice, are there any other ways to communicate over email or text messages? If I need something simple like change of prescription or
So we have a portal. So and then there's also a phone line where people will call to kind of get in, you know, if they want to talk to a person. The problem is that this is a large university. If you don't send me the message through a portal, which a lot of my older patients not able to, you know, they just don't use the portals. But if they can't send the message through the portal, then they have to call, and the phone lines are not always easy to sort of get things done through. It's a very large university, so it's not administratively run as good as my private practice, but it's insurance based. So, and so basically the reason I do it this way is that when I'm in university practicing mostly geriatrics, I don't, not only, but 2/3 of all my patients, there are people over 65. My practice there is more in line with standard of care. I always talk about prevention. I always talk about integrative modalities, but first and foremost, I'm going to follow a standard guidelines. You know, I'm going to suggest.
You have to.
I have to actually, and that's essential. So I have to. I mean, I will sort of suggest vaccinations, even if somebody's coming to me and they're strongly opposing it, the whole principle of vaccinations. That's their choice, but I have to by law suggest that and document that we talked about it. So like, this is just what legal system requires. But this is why I don't practice in just one place. So in my private practice, we're 100% out of network. We're 100% out of, because there we don't practice standard of care. It's 100% integrative medicine. It's 100% prevention, but it's expensive. Because of that, if you don't have a Cadillac insurance that will reimburse you for any visit to any provider, then you're probably going to be quite, you know, at least a couple of $1,000s a year. If you're going to see us 3-4 times a year, it's going to be pricey. But a lot of patients feel that that's the value they would like to pay for. Yeah.
What I'm trying to understand is if I can communicate over the portal right? Sort of to reduce that cost. It's very simple approach. Is it going to cost me arm and leg if I just email you and say, okay, that brand of vitamins out, I need to change to this. Is it okay?
Right, right. So that's a great question. So a lot of practices right now, and I know quite really good practices in Boston that do that, where you would pay someone an annual fee to have that unlimited access to the messaging. We do it a bit differently. So in my private practice, we don't charge people for that at all. But if the number of messaging becomes significant, we will simply bill on time. So we will say, look, I spent an hour a month on your chart, so I'm going to bill you for that. If it's one quick question, usually we don't. But there are also some patients in our practice who are also in the concierge because they want to have a kind of premier access. So they would want to get in quickly. They would want to not worry about number of messaging going back and forth. They want to simply call my office and say, I need to talk to Kogan tomorrow at 4 o'clock, and then the call placed back. So they kind of value that relationship. We pricing this at $1,500 a year, which is kind of probably about an average for most practices. Usually it's somewhere between $100 to $150 a month in our area. You know, in some areas.
Yeah, I think
more
it's
or less.
pretty much the same in the Boston area. From what I've seen.
Right. But it's sort of interesting because I was just reading a New England Journal of Medicine article called Death by Portal. Physician in Philadelphia and Jefferson basically got burned out completely because she was spending 2 hours a day answering messages through Portal. She felt bad charging for it, and she basically quit.
Well, I mean, you need to find the sort of right balance. I think.
Right, because people often, you know, we find this quite often, and patients would message us minutia that they can figure it out, or it can simply wait till the next visit. But as you pointed out, when certain supplements, for example, are out, like how do you replace that, right? So you need to have a system in place to manage this. Usually, we have direct access to all of us. And then, you know, basically, if the patient is in the concierge, then it's unlimited. If they're not, then we just use our judgment. You know, if it's a one quick question scheduling or something, we'll simply forward it to front desk. If they have a clinical question, we often say, you know, you're not in concierge, so I suggest you make an appointment. But if it's something that I can answer in one little line, that's what I'll do. And I think the same way with insurances. So, you know, I would simply respond to a patient through the portal with one line saying, you know, we need to talk or something like that.
What if, let's say, I need a prescription or a blood test?
So the prescriptions are renewed automatically. So now everything's electronic, both places. We have 100% electronic. So they basically send automatically to the pharmacy to get renewed. So the blood work is a little trickier. Sometimes I would simply order it, but the blood work often requires conversation because it's not usually that easy unless it's something very routine and like, let's say you're monitored for something and then, you know.
Well, I'm monitoring, I can give you an example. This year I've dedicated to figure out my ApoB, heart health, cholesterol. So I did all the readings. I spoke with my doctor who now retired, but I decided to do several basic interventions. Try niacin for a couple months, see what happens. Try a high dose of omega oils for a couple months, see what happens. So I need to do baseline ApoB blood test and maybe some inflammation markers. Then I need to repeat it in 2 months. Then I've been taking omega oils for another 2 months. I need another blood test. Is it, and I probably don't need like a whole appointment to do that.
So what you're describing is a perfect patient for concierge practice because you're basically saying, look, my needs are not your typical needs when I only going to call you for emergency. My needs are continuous. I have multiple things I want to think about. I value my health to a point where I understand that I don't want to sort of wait till the next appointment. I need to do a whole bunch of stuff. And because it's routine and we don't have to talk, you know, so basically when you enter concierge agreement on your end like this, you telling your doctor, hey, I value your time. And more importantly, I value our relationship. One of the problem people don't realize in US, right? Most of the relationships are commercially based or they're professionally based, right? So they should be appropriately set from the boundaries perspective. We often don't realize there's a lot of situations where patients would send some things that are clearly cross the boundary into this is not a professional communication. So when you create the financial agreement with the provider, you're setting that boundary in place from the beginning. You understand the rules of this communication, and within that, that's when you're going to get the best results. Looking for a practice in your situation, you're looking for a physician who's going to say something like, oh, you know, I'm going to bill you every time you email me. That's probably going to run into lots of trouble for both sides because.
I mean, I'm okay with either way. I just want to know ahead of time what I'm getting into, and I want
Right,
to establish
exactly.
proper channel.
Exactly.
And everyone can decide if it works or not.
Exactly. Exactly. My point is that a lot of the times when people think through this, they don't realize that when you create that arrangement, you make it clear for both sides, and it's a path to success.
Yeah, I always say that it's better to know what's going on than be in the state of unknown, because it's just more stressful for everyone.
Exactly. The classic path to failure, which actually for some reason a lot of our Russian friends follow, is this. They find a good doctor somewhere in academia, like in a large university, because somebody said, oh, this is the best physician for this. But they don't realize that for the doctor may be genius and wonderful, but if the infrastructure is not set in place right for what you need, it's a total disaster. It's a total, this is when things fail, because you're going to try to reach your doctor, not because they don't want to, but because the system not in there. You're not going to be able to do that. Or if the system is in place, but the doctor is a researcher, educator, and they're only in clinic 1 day a week, and there's just no way for them to communicate with you frequent enough, you're going to be constantly frustrated. So you really need to look for a practice that you're happy with the person who's in charge of your care in essence, and B, that you're happy with infrastructure. And that's, believe it or not, that second aspect is almost as important as the first one, because quite often, especially in the current healthcare system, a lot of infrastructures are just not designed. They designed for medical emergencies. They're not designed for preventive care.
That's what I always tell my friends who not in the States. I said, medical system here is great for emergencies.
Exactly.
But everything else, nope.
Nope.
You have to just know.
So in my private practice, our system designed for the prevention, right? We have direct access to every provider. The patients can just send, because in a lot of practices, you don't even get to send a message directly to your doctor. It's going to go through checkpoints, like it's going to go through the administrative layer first, and then they may not even get everything. So that's one. The second is that the way system set up with us, patients can send us attachments of any kind. They can send a picture. They can send a file from somewhere else. They can send, not just a link, they can send direct link that I can just click right out of the chart instead of like sending me a paper copy of something by mail, which is what we used to do before the portal.
So let's continue with me. I started to talk about my APOB adventure, but I want to hear your angle also. What do you do for preventing heart disease, cancer, dementia? What are your I don't probably don't need an hour lecture.
Right. Well, so the one thing with us is that we're the personalized medicine is for us already past point. So we're already beyond personalized medicine. So we're in the area where we're combining personalized medicine with functional medicine, which is meaning the following. I will first understand your personal risk factors, which usually involves comprehensive genetic assessment, which usually involves assessment of pretty much every of your system. And we don't do that by just getting a basic blood work. We do a lot of functional tests where I would look at a particular organ, let's say digestive tract. And I would say, well, your imaging may be perfectly fine, but your bacteria is off here, your digestive enzymes are low, and you're not processing your fats well because they're coming out in the stool. So like we would look at this from not diagnostic perspective, but from how is your organ operates. Yeah. So, and then within that, once we identify your weak links, that's what we're going to concentrate on. We're not just going to say, oh, your ApoB is elevated, and so it's an inflammatory response.
Why,
Let's
right?
go. But why?
Mm-hmm.
And that why could be not necessarily have anything to do with your genetics. You could have some toxin hidden somewhere, and that causes an inflammatory response. Or you may have some particular nutritional deficiency, which your certain needs are not met. So like methylation is a very common problem, but 40% of Americans, I mean, of course, you know about that, but a lot of people don't. And so like we would test for that, and we would say, oh, okay, so you have genetic reason in this case to not methylate some of the enzymes very well. So you need some methylation support to get specific detox and specific processes in better place. So that's the way we think. We don't think in terms of particular problem. We think about why is that problem there. So this is the core difference between integrative medicine and the standard Western model, because Western model treats diagnosis, and it doesn't go beyond that. It simply says, okay, you have lupus. Well, here's here's the immune suppressant for your lupus. We don't stop there. We say, okay, well, but why is this person developed the lupus? And
so is there any chance for people who go to a regular doctor to get any of that? What do you say?
Highly unlikely. And the reason has nothing to do with what this doctor wants.
Just there is no way to diagnose and put a code on it?
Exactly. This doctor is limited by the setup. If they take insurance, by default, it means that they will have to follow the standard recommendation, or what's called a guidelines. So each disease has a guidelines on how to manage it. Let me give you a very simple example: diabetes. In the diabetes, there is a lip service. Yeah, there's a lip service for lifestyle. It's all okay. So your number is this, you're going to give this drug. Your number is that, you're going to give that drug. This is how it's practiced. Nobody thinks about something like, okay, let's just pause for a second. Why does this patient have diabetes? What are this person's, and often within that thinking, one of my first cases in my practice was a man in his 30s who was diagnosed with type 1, not type 2. And, he was said, okay, well, okay, here's your insulin for the rest of your life. And when I first saw him, I'm like, this doesn't make sense, right? So what we did is we did a very comprehensive toxicity workup. The guy was a painter, and he had a horrendous paint toxicity. Okay. We detoxed, he stopped using it. Diabetes went away completely. Off insulin, total normal life 3 years later. So you have to think of deeper. You can't stop at the way the medicine dictates us how we practice. And you as a patient need to be in charge of this. And so your doctor has to, at the very minimum, agree with what I just said. They may not know it. You may help them to teach them. If you're limited on your resources and you can't get into concierge and you have to use insurance, but at least the doctor has to be open to you saying these things. They have to be reachable. Right? For your questions and
systems.
Yeah, exactly.
So what do you do about cancer with all that approach?
Well, so we have a very complex, very large cancer program, kind of in conjunction with some of the things at the GW at George Washington University, breast cancer. We have a lot of parallel. We actually do some mindfulness workshops for the breast cancer and other things, research program.
But general prevention.
General prevention, right. So the general prevention is a bit, again, same principles.
Or early detection, because with cancer, early detection probably is valuable.
Right. So actually we get more of a patients on the other end, so which they're kind of failing the treatment, or they want some other integrative approaches like intravenous vitamin C for cancer, for example. So they'll come to us. But in cancer prevention generally, it's a lot more complicated topic. Of course, we'll do the same standard screening like every other office will do, but we also will look into kind of this more of a biochemistry and say, okay, your sugar is high. I mean, and you may be not diabetic, but you're pre-diabetic, and that's bad enough to increase risk of cancer. So we will work on that. So often also our ranges for specific things are a bit different. Right. So some people
what I like to say, there is optimal, and optimal is not always
Let me ask
what
you
you
a
have on the
question.
blood chart.
Let me interview you, because when
Okay.
you're doing this interview, by the way, it's just as important that your doctor interviews you too.
Mhm.
I'm going to ask you a question. What is your homocysteine?
It's about 7.5.
So we would click really well, because I say, perfect, you're under 9,
Yeah.
you're at the target. But if you go to a regular physician, and first of all, they'll never ask you this. Second of all, this, if you ask them, what is your optimal homocysteine level, they're probably going to say, well, whatever the lab tells me.
Yeah, between 5 and 10 or whatever. And I'm like,
No, the
sorry,
normal
I don't
lab,
want 10.
the normal lab is going to say 15 to 20.
Oh, 15. Okay.
Yeah, or like 14 to 20. Screw that. It's exactly right. That's like, okay, I'm not looking for disease state here. I know that homocysteine over 10 is a problem. So everybody should be probably under 9, or at least between 9 and 10 if possible, but definitely not over 10.
Yeah,
So
I just saw, sorry, a big study that, again, it's more for dementia, but if your homocysteine is higher than, I know, 8 or 9, your chances of dementia are 20% higher.
That's exactly right. But
Like,
you'll
no,
ask,
thank you.
but most doctors have no idea about that. And the good news is the treatment for this is very easy.
Very simple, yeah, just get methylated vitamins.
Yeah. Or you also can actually do certain foods. If you don't want to take supplements, you actually can. Cara Fitzgerald has a very good book that is actually, I don't know if I have it here sitting somewhere. Probably not. It's probably at the office. So that book describes very well as to exactly how to achieve it with diet alone. I usually recommend vitamins just because it's much easier. It's usually you take a couple of capsules of methylated B vitamins, and it works more predictable than the diet in my
again, in my case, I have it MTHFR, so
right.
I kind of have to pound on it heavily. But with cancer, do we do something advanced like liquid biopsies or some extra MRI scanning?
So great question. I'm going to give you an answer you may not like. So for example, I strongly discourage people from doing imaging. And here's why. First of all, the quality of current images detecting an actual cancer is poor. You're going to have a lot more schmutzes, what we call them, on the images, which is an iatrogenic.
Of course.
You're going to find things that are not cancer.
Yeah.
You're going to find things, and you're going to go and you're going to have to work it up. And this is where you're going to get a biopsy. They may find some atypical cells. And this is where, remember that I told you 750,000 Americans die every year from wrong diagnosis. About 10% of these patients die because of the wrong diagnosis of cancer. They are told they have a cancer and they don't. I actually have a very famous case in my practice where a patient was told he has a pancreatic cancer while it was a benign tumor. It was a very small, they basically took his entire, it's called Whipple procedure. They took the part of there's a massive procedure.
Yeah, but there's always a risk.
There's a risk. They find something on imaging and then they're going to, so I'm very skeptical. Basically, the way I think of it, we look at this a little different. First of all, we look at the kind of a biochemical risk first. Then we add blood work. Whether, we like liquid biopsies. We also like some specific markers of inflammation. Things like, the certain things people never heard of, like VGF, for example. We like IL-6. We like certain things that are showing me if those are elevated, it's an atypical inflammatory response. It could signal the cancer. Then we would proceed to something like a liquid biopsy or whatever, some other. Or not just liquid biopsy. We could also look for a cancer cells, progenitor cancer cells, or sort of cancer stem cells in the blood. That's also a very effective test. And if you find them, then you're really concerned and you need to treat the whole body rather than just take a chemotherapy and radiation to a specific organ. Let me give an example. Let's say you have a breast cancer, right? And you're going to have a surgery, and then they tell you you're going to give you chemotherapy and hormonal treatment. So if you do the liquid biopsy and you find, and also do the cancer stem cells, and you find nothing in the blood, this is where I could potentially say, wait a second, let's just not rush this, get the cancer out. If the nodes are negative, why don't you just take a hormonal treatment then, because the chemo is going to be pretty toxic and the radiation is going to be pretty toxic. So there are more newer methods like this, and often they're kind of on the fringe. A lot of oncologists will not do these tests because they're often not covered by insurances. Some of these tests are very expensive, like some of the liquid biopsies are way over $1,000 each and never covered. So, you're looking at some of the sort of associated costs here, and common oncology practices, if they're 100% insurance, they will not include anything that's out of pocket, regardless of the evidence. That's just the way systems set up. So if you're going to go to your oncologist or your internist who works with an oncology practice in the same group, and you're going to say, I would like that, they're probably going to say no, not because they may 100% not support it, but because they don't have a system to order the test. So they will tell you, well, good luck, go find it somewhere else. And they won't have a system. They wouldn't want to set up a system how to get this because it's an extra work for nothing. So remember, medicine is business.
Yep. Yeah, but my approach is that, and that's why I said not just MRI, but MRI and liquid biopsy and maybe something else, because you want to get more angles. Because again, that liquid biopsy is not going to give you 100% result anywhere.
Correct.
It's also MRI. But if you have at least 4 or 5 markers all pointing to the same direction, then it should be, okay, I probably should do something and not wait for, huge tumor, which will be found out in 10 years.
Well, for you and I, there's one MRI that's probably going to be very relevant in some 10, 20 years, which is the prostate MRI.
Prostate, yep. Yeah.
That's one MRI.
Not everyone dies from prostate cancer, but everyone male dies with a prostate cancer.
That's exactly right. That's 100% accurate statement. And because of that, it maybe makes sense to get an MRI at some point to say,
just to see what's your baseline and how does it changes.
That's right.
Yeah, because not everything has to be treated, but you need to be aware of.
Or the treatment doesn't. I published a couple of years ago a case. We had a gentleman who came to us with rapidly rising PSA, early cancer on the biopsy, MRI clearly showing the cancer was limited to the prostate. It didn't spread yet. And so he said, I'm not going to take any standard care. And actually nobody offered him much because his Gleason score, which is the severity of kind of pathology of the cancer, was pretty low. It was 6. So his urologist said, we're just going to monitor you. And when he asked, what does that mean? They said, oh, we're just going to check your PSA every 6 months, but you don't have to do anything, eat whatever you want. He's like, whoa. So he came to me and we created a very interesting complex protocol. I can send you an article if you're interested. And part of that protocol he found on his own to use cannabis. So we actually use rectal cannabis as part of his treatment, and he's got cured. In a year, there is no cancer anymore. Just went away. They repeat the biopsy and there was no cancer. So we published this case because it shows you that often if you have time and you can safely implement some of the cancer treatments that are completely natural.
Yeah, you could definitely try them.
You can try them. You have no risk, right? Because if they're not doing anything, then why not? Like the other cancer, which is very common, relatively speaking, it's called chronic lymphocytic leukemia, or CLL, which is I often get patients call me because I also had some success in treating this particular cancer. So you just kind of explain to them and say, look, this is what we're going to try, and if it works, great, and if it's not, when your oncologist tells you it's time to do whatever, then you'll do
just go with that.
Yeah.
And it doesn't mean that you cannot combine several treatments.
That's the integrative medicine.
Yeah, because somehow a lot of people I see, they like to go to camps. We only do standard or we only do natural. Like, try both.
Exactly.
See what works.
So that's actually a really important point. People who tend to do only one direction, they're missing out. I would say people who just do alternative missing out more, because when they're going to get an emergency of some sort and they're going to refuse a standard of care, they're going to be in a major risk. Although, you want to hear the funny part? I'm yet to see a single person when they actually have an accident, like a car accident, or they fell on the skis and they broke their leg.
Refuse the standard.
They will refuse the standard of care. So they will say, "Oh, I'm all natural," but then the accident happens and they'll be just as happy.
Give me morphine.
Give me morphine. Exactly. So I think that there's a it's not black and white. It's all kinds of shades of gray, and the reality also, people's opinion changes, and experience changes. And so, quite often people move on that continuum from one spectrum to the other. But the people who are on the right, only standard of care, they're actually missing out a lot too, because often, I just said it, and I will put the link to the study. I mean, this is British Medical Journals. And we all knew about this. Like, I've been advocating for less medicalization of healthcare for a very long time, particularly for people who are over 50. When you're 35, you're simply not entering healthcare system that often. But once you reach a certain age, it's just statistically speaking, the chances of entering healthcare system for all kinds of reasons going to go up.
Yep.
And the problem there is when you enter the system that is highly inefficient, that makes a lot of errors, and that treats everything with a hammer when you may need a feather, it's just not right. And so that's the thing, like finding the provider who will always support your journey and understand your values is actually
and limitations
and limitation. Exactly. And when you're sort of saying something crazy, they're going to redirect you and say, nah, let's just, and there has to be this trust also, like some bilateral trust where you need to understand that your provider is always going to be supportive, and they're not going to tell you something because it's simply they make more money or that they're just whatever, right? So that they're always going to have your interest first, regardless of what's happening. And that also could mean tough truth, because there are practices that I know, and I'm not naming anybody, they will simply just follow whatever patients tell, and they say, whatever, and we're just here to make money.
Bad,
that's also bad.
I want to triangulate.
That's
yes,
right.
I value my opinion, but I go to
right.
professional to get professional
That's
opinion,
right.
not just agree with everything.
That also brings me to an interesting point. You probably don't want to have one doctor. You probably want to have a healthcare team. And the reason for that is this. That first of all, the time of the doc in a box, what we used to call, or like this idea of a rural one doctor takes care of a whole village kind of thing, that fantasy is all gone long time ago, more than 2 decades ago. Somewhere in early 2000s, such a model just completely disappeared. And it's simply with our current complexity of healthcare that is infinitely increasing. It's exponentially getting more complex.
Too much information.
Too much information, specialization, interest of providers, the fact that your system in place may not support certain broader things. It's just all kinds of reasons. It's not just one reason. You basically want to say to yourself the following: what do I need as a patient? What are my weaknesses that I will need to support for a long time? And here how I think. You need a gatekeeper. So you need a person who knows a little bit about everything, who can be your mirror, who can reflect to you what is happening, who can reflect to you and say, hey, I hear you, but let's try this. That's one. But you also need providers within your weak link. Let me give you an example. You mentioned methylation. A lot of good primary care doctors will have no idea what you just said, right? And it's not their fault. And you may say, look, that's fine. You don't know this. I'll just find a nutritionist who I'm going to meet on an annual basis, who understands all this. They will
do the right tests and right things.
Or even better, where that nutritionist can work with your primary care doctor, and then the nutritionist will send a message to your doctor, say, hey, doctor so and so, can we get this tests? And then I will take care of the managing that. So that's what you want. You want this kind of a collegial working relationship. But let's say, let me give you an interesting different example. Let's say you have scoliosis your whole life. And because of that, you have a mild chronic back pain. And because of that, your pressure on your skeletal system is a little different. And because of that, if you do certain activities, you have more pain, you're more likely to fall, you're more likely to have a certain specific trauma.
Some risks.
Yeah, and so suddenly I may say, you know what? The most important 2 people for you, more important than me, are going to be an Alexander Technique master.
For balance and
and also to optimize. And also some kind of a manual therapist, whether it's a physical therapist, a gifted massage therapist, it doesn't matter. But so suddenly, it's even more important if you have Ehlers-Danlos syndrome variant, which is a connective tissue laxity, which is about 10% of entire US population. It's not a small amount. Those are the patients who usually have like chronic fatigue syndrome, and they have chronic traumas all the time, and they have very unstable blood pressures that goes up and often very low. So what's called a POTS, postural orthostatic hypotensive syndrome. And so basically those are the patients who will need that manual work a lot more frequent. They may create some kind of an ongoing long-term model where they're seeing somebody on a monthly basis paying a membership model, because you don't want to often think about, oh, do I need to go see someone? Like, I personally feel anybody who's physically very active must have some kind of regular body work, and so it may just be easier if you, especially if your insurance will
schedule.
Yeah. And even if the insurance doesn't pay for it and you're going to still go for it, well, pay them annual fee so you don't have to worry about, and you always have access to them.
Yeah. So my last question here was, it's not really a question, I called it a reaction. Because what I wanted to on the interview, but with you it's too easy, because it looks like you want to work with people who are proactive. That's exactly right. But do you have any recommendations? How do you find a doctor who actually on that side? Because I've seen in my experience, again, doctors who just want to be authoritative figures who don't want to listen to anything. They have procedures you have to follow, or
Well, I'll give you a kind of a there's a kind of a Google search option basically, and the keywords there would be integrative medicine, lifestyle medicine, definitely functional medicine, and also I would use, if you're state licensed naturopathic doctors, I would also use that as a search. And then you have to also decide the cost, right? So there's a lot of pragmatic things that go here. Like, if you have a very good insurance and you don't want to spend your dollars for whatever reason, that's fine. I mean, then you would need to see who is in the network there, right?
Yeah,
so
because I have to have primary care. So
right. Well, that's an interesting point. So the primary care, the way we currently think about it, this goes back to 70s, and I'll explain. We have a couple of minutes, I'll explain that. So in the 70s, there was an international, very important meeting that actually held in our former alma mater in Alma-Ata in the former Soviet Union. And well, not in Russia, but in Alma-Ata. And so basically there was an agreement that countries that try to do a good primary care are going to establish a system. And every country that was there was about 20 countries, except for the US, followed that. So what happened? Cuba developed the best primary care in the world. And that's why they're dramatically better healthcare outcomes than US. They're not even in comparison. Cuba sits in top 20 to 25 healthcare systems in the world. The US is not in the top 50.
Yeah, it's
like probably 69, I think.
If US you look per dollar, you probably
forget that. That's the last. No, but I'm talking about the general outcomes.
Yeah, outcomes,
general outcomes, right? So US is not in top 50. It's kind of continuously falling down. And Cuba is continuously going up. And that is why, because they created a profoundly effective primary care system. We don't have primary care system in US. Your insurance tells you to get a primary care doctor, but the reality is it's just because the insurance says so, because they need to have a referral for every visit you make to a specialist. So you have to have somebody on file. But what you can do with this situation, when you have a limiting, not very good insurance, here's how I always tell to my patients: get the maximum flex account or HSA account, health saving account. Maximize amount of dollars you can put in there.
Absolutely.
Get your primary care. You may see that doctor every 5 years, whatever, if you're completely healthy, just so that if something does happen, you have a system in place. But then find the practitioners who's going to support your health, right? Not your emergencies. Because if you're in your 30s or 40s, I mean, emergencies can happen. You're very active. You go skiing, you fall down, you break a leg. Okay, fine. You want to have insurance for that. Like, one thing I will actually say for your listeners and for my listeners, do have insurance. I mean, it's not appropriate, and it's actually, I would say, crazy in this day and age not to have insurance and
Yeah,
think
especially
that
in the
nothing's
States. Yeah.
just simply because of one factor. If with this situation you will end up in a hospital for whatever the reason is, I don't know, there's all kinds of reasons. The bear attacks you in the middle of the forest, right? You will be paying for this for the rest of your life, because this could be, your bills could be in hundreds of thousands, if not millions of dollars, if you don't have insurance to cover. Even if you do have insurance, you can still have a horrendous copay.
Yeah, I think it's still one of the first things which makes people go bankrupt.
Exactly.
But if you don't pay negotiated rate, it's going to be like
then you
more than your mortgage.
Then you're completely cooked. So you have to have insurance. The question is what kind of insurance and all that. We don't have time to kind of go into that. I think it's also highly individualized. I often say you don't have to sometimes get the best possible insurance, because you're going to be paying a lot of money per month. And quite often,
It's better to spend those money on a doctor, on a test.
That's it, is to spend out of pocket money, put that money aside and target your health, instead of target like some pain, and then just anticipating a hospital admission being 100% covered no matter what. Because if you're relatively healthy, you're probably never going to, or you may not never need it. But then setting aside a budget so that you know how those dollars are spent, and they're spent on your health, not on your illness. This is the critical aspect. When you enter a standard healthcare system, 90% of entering that happens because you have some problem. You have to learn to enter healthcare system because you don't want that problem, because you want to stay healthy. And right now, there's no system in place. US does not have system in place. The prevention and entering for preventive services, the way it's organized has nothing to do with actual prevention. It's really early screening for 90%. You can have a great doctor. Like, sounds like the guy who just recovered was a great doc who was working with you. You can be lucky and find, if you find person like that, hold on to them for your dear life, because those are not common. Rare breed. Exactly. Yeah, I would say it's even more rare breed for them to take insurance. I mean, I think that especially when you're in a large town, if you're in a large city, a lot of the doctors like this basically cannot compete. They're simply doing, they're not getting paid as much. They can't build their practice. They tend to be smaller. They often tend to like to practice the way they like to practice. That means they're gonna not subscribe potentially to some complex large centers, like whether it's academic or for profit or whatnot. So you're just not going to get a care that is, you're gonna get a kind of a care that is based on the system that's established there, not based on that, just on that doctor. Because again, as I said, I think that one-on-one kind of one doc office things are basically going away rapidly, unfortunately. But on the positive thing, I think we're all going to start using AI in the upcoming years. We're all going to start using coaches. I think a lot of coaching will shift to AI. In fact, I think most of the coaching will be AI based, and it will be a lot more efficient than currently. It's probably also going to cost a tiny fraction of the current costs. In fact, here's the idea. If one of your listeners is a coach, I would be very careful, and I would start looking for some other job, because I think most of the coaching jobs in the next 10 years are going to get outsourced. Yeah, because it's just,
or you get on top and use those tools, AI
tools
actively, so you know how to prompt them and be more efficient with your time.
Exactly. So you will be more like suddenly like more of a gatekeeper of AI, and then kind of do that and have much higher volume of patients overall, even though you're going to see them a lot less frequently. Exactly. Yeah.
So it looks like, at least to summarize, for my situation and probably for a lot of people, it makes sense to have a primary care who is open-minded and can send you to the right specialists, and possibly have a second doctor, like a functional doctor, who might be out of insurance, but you still see him once a year or twice a year to do some extra work, extra tests. And of course, all of them has to be selected carefully, probably with all the questions I've asked. Just
And
don't
know your
rely on it
know your
on luck.
weaknesses, know your
Know the
weaknesses,
weaknesses.
and create the system for those weaknesses that is not necessarily engaging physicians, that engages other provider that may just be better suited. I mentioned physical therapists, for example. In fact, in my practice and for myself and for my family, I actually we have primary care on file, but I haven't seen that person in 7 years. But I have a physical therapist who I see at least twice a year. Why? Well, because I have certain musculoskeletal challenges. I'm very physically active. I exercise a lot.
You want to get aligned.
Yeah, I need to get
then.
aligned, and also because sometimes stuff happens. I will fall down, or and then so I will go and see Jessica and say, oh, this happened, and then because you also don't want that to accumulate. You don't want those micro traumas to become like growing concern, and suddenly you have all kinds
That's
of
a good point. Yep,
musculoskeletal.
that's a good point.
Prevention, instead of being proactive, instead of being reactive. Act to your healthcare challenges early as you can possibly do so, and then put some kind of a live to 150, follow Alex program, because that's actually, I think, why not? We have all kinds of tools now, and I think the science is marching forward.
I mean, there is no downside from, at least from my point of view. Because if you align yourself with that thinking, you're more likely to make the right choices, and if you make the right choices, you suddenly live longer.
That's right. Yeah,
it's
I call this approach age-wise. I have a book published by Oxford University Press coming out sometime in the spring next year. Now, there's a lot of books on aging already, but I think my point here as a geriatrician goes like this. A lot of the anti-aging out there is completely impractical. Like, you did this wonderful comparison. There's this guy, what's his name? Is it Johnson? You know who I'm talking about, the guy who does like hundreds, if not thousands of tests.
Yes, Brian Johnson.
And you did this wonderful video where you're like, but if you just do this couple of things, it's probably going to be just as good. So that's the way I think. I think in those terms, what are the sort of the core package that you have to do?
Yeah, it's like a Pareto principle. Can you do
But then I also,
which moves the needle.
Exactly. But then on top of that, I add what are the things that you should anticipate, and more importantly, when you already have certain challenges, because most of us, let's face it, right?
Yeah, we'll do.
We don't have $2 million and a team and per year and then follow all this. The reality is we all coming to it with some package. So there's going to be some help. So the book is all about, when you already have this medical problems, how do you integrate those problems with the healthy approach overall as a prevention? So.
All right, so I think I could probably wrap this up.
Yeah,
I would add that you still need, even if you have a great doctor, you still have to educate yourself.
You must. Don't.
Absolutely must.
You are the best doctor, and one of my favorite clinicians of all times, Melinda Ring at Northwestern in Chicago. She did a TED talk on this. That's basically, you will always be the best doctor for yourself, and do not ever try to find a doctor to replace yourself, so to speak. You have to know your health better than anybody else, and that's often a mistake that people think. They're going to think, oh, my doctor knows me. Oh, I have this, I'm going to go and no, you have to be responsible for your health first. You have to understand your challenges. You have to know how to handle them. You have to know who you need to access to optimize things. Do not rely on anybody else. Not because if you're super rich and you can create like a complete team, even then, because in reality, those people will never know you as well as you know yourself.
You still need to be in charge.
You have to be in charge.
We like to say that educated people live longer, but it's not just because they have more income. It's because they make educated choices.
Decisions. That's exactly
right. Educated decisions.
Which brings me to my kind of favorite last point, which I always say, in my heart, I grew up in Russia in social medicine. I value that. I value that what we're talking about should not be expensive. It should not be only for the whites and for the people with money. It should be for everybody. We started this small nonprofit, Pain Health Institute in our area, to sort of just to say what we're talking about should be for every person. And having the access to a really good medical team is the human right. Unfortunately, states of America don't think that. They think that the healthcare is a privilege, which, I highly disagree. We both grew up in a society that was saying the opposite. Not that society was doing it well. Put that aside. See that my dogs agree with that.
Well, it comes in the package. You need to understand the limitations and benefits. And especially if you're in the States or any Western country, you need to be in charge of your own education. That's just how the system works. I actually just made the video about Dunning-Kruger curve.
Yeah, I saw it. It was really cool.
So that's anyone watching. What's there next?
Yep. Subscribe to Alex's. Yeah, I love how you make every point that you cover not just very easy and clear to understand, but very visual. I need to learn how to do that. So thank you so much.
We'll leave all the links below for Misha's channel, for my channel, and maybe we'll do it. Ask your questions. Maybe we'll have more conversations.
Yeah, and if you listening to this and you're like, oh, they didn't talk about this, we're humans, right? We make mistakes. Put the comments. We'll come back together. You see that we're in sync. We like talking. We'll do another one soon. Hope everybody's having a good day.
Right. Thank you so much.